Hello, my name is Mary Hay, and I'm one of the speech pathologists here at Memorial Hospital. And today I'm presenting on dysphagia. So I just brought up a few facts about a normal swallow, aspects of a normal swallow, just because I thought that it'd be interesting to see. Normal swallow is completed in 1.5 seconds, so that kind of gives you a frame of reference of how fast a normal swallow should be. The basal ganglia, thalamus, limbic system, frontal lobes, hypothalamus, in addition to the brainstem and cortex, are all needed for swallowing, so we use a large portion of our brain. The swallow has voluntary and reflexive components. And that's important to know because sometimes I have patients who cannot follow commands, but they can swallow at the reflexive level. So sometimes when the bolus goes over the base of the tongue, it'll trigger that swallow at a reflexive level. So you can't always tell. The swallow generally involves over 26 muscles of the head and neck and involves 6 cranial nerves. Whoops, I went the wrong way, sorry. There are several pharyngeal reflexes that have to occur. I also wanted to list these because it's important to understand that for a normal swallow, you have to be able to trigger these reflexes in the right sequence, in the right timing to get a good swallow. So the swallow is a lot more complex, I think, than most people realize, and because we do it so often and without even thinking, that any of these get out of sequence or the timing of any of these reflexes are off, it can cause you to have difficulty swallowing. So when speech pathologists evaluate a patient's swallow, we are looking at a lot of various aspects of the swallow. And so I wanted to kind of quickly go through these just to point out that when it's a big difference between when staff is screening a swallow versus speech who's evaluating all of the function of that patient's swallow, that we're looking at a lot of different aspects. Lip closure, tongue control. It's important to be able to control that tongue in order to prepare a bolus. And a bolus is what you call the food in your mouth when you've manipulated it into a ball. How well the patient can transport that bolus over the base of the tongue and into the pharynx. We also look to see if there's any oral residue after they swallow. We look to see initiation of the pharyngeal swallow, and we look for a brisk superior anterior hyoid movement, so that's up and forward. The hyoid has to move. We look for soft palate elevation, which you can't see at the bedside, but you can see on a swallow study. So the soft palate has to move upward and close off your velum, your veopharyngeal closure, so that nothing goes up your nose. The other important thing about palatal elevation is that your swallow really needs to be a closed system in order to build up pressure to squeeze that bolus down, and to help with airway protection. So your soft palate has to close off your nose, and you have to close your vocal cords and cease breathing and get a completely closed system to get a good swallow. So if you have air escaping out your nose or out your trach, if you have a trachea, a tracheotomy, then it's much harder to swallow. We look at, again, laryngeal elevation, how well that pharynx elevates and larynx elevates. We look at anterior motion of the hyoid, so the hyoid has to move forward. We look at the epiglottis, so this is on the swallow study. We'll look at the timeliness and complete epiglottic inversion to meet your arytenoids. So your epiglottis has to come down, bend over completely horizontal and past and all the way down, and make contact with your arytenoids in order to close off your laryngeal vestibule to keep food and liquids out. We look at how tightly that the larynx closes, so the laryngeal closure, and that's, again, the arytenoids coming in contact with the epiglottis. We look for the pharyngeal stripping wave, which is a wave of muscles that occurs down the posterior wall, and it kind of follows the bolus down in a wave. We look for pharyngeal contraction, where the actual pharynx raises, all the muscles shorten and raise up. We look for the relaxation of the pharyngeal esophageal sphincter, which is that muscle that's a sphincter muscle at the top of the esophagus. And when you swallow, your hyoid pulls up and forward, your epiglottis comes down, and that muscle at the top of the esophagus has to relax in order to let the food and liquid go down. We look for tongue base retraction. So when your tongue base actually goes all the way down into your pharynx and into the vallecular space, and so when you swallow, that tongue retracts against the posterior pharyngeal wall and helps kind of push that bolus down as well. After the swallow, we look to see if there is any pharyngeal residue. So many times at a bedside, you cannot tell that the patient has not cleared the material from the vallecula and the piriform sinus. So after the swallow, if they have a weak swallow, they'll have a large amount of material still in their pharynx that you can't see from a bedside. And the patient often won't feel it, won't know it's there. Sometimes a normal swallow, you'll swallow, not clear everything down, and you'll automatically trigger a second swallow to clear. That's not too unusual. But in a lot of patients, they don't trigger that second swallow, or they don't know that there's still food in their throat. And then we look for clearance of the esophagus. So we make sure that everything clears through the esophagus and into the stomach. Here's kind of a picture of the anatomy of the swallow. Bob, I'm going to walk up there and point out a few things. Okay. So this right here is your airway. This is your hyoid. This is your epiglottis right here. And if you read our swallow studies and you look at them, we'll talk about the vallecula. So the vallecula is this space right here, and that is the space that occurs when the epiglottis is in an upright position. So sometimes we'll say the patient had residue in the vallecula, and that's where we're talking about right there. Lots of times when your patients say, my pill's stuck in my throat, it's usually stuck in the vallecula right there. If that's the case, sometimes just drinking some water or taking a bite of some food will help move it down. This is where the top of the esophagus right here, and the sphincter muscle is here. So when you swallow, your hyoid goes up and forward in this motion, and your epiglottis will come down and meet your arytenoids here and protect your airway, and the food and liquid will go down the esophagus and hopefully not into your lungs. So that's just a quick peek at the anatomy of the swallow. I'm going to switch gears a little bit to talking about the importance of saliva. Saliva is extremely important, and as any nurse knows, people in the hospital all have dry mouths, and especially if they're not eating, that they have thick secretions. And so the major salivary glands are the parotids, which produce watery thin saliva. They're very important for eating and drinking. The submandibular produce both serous and mucoidal saliva. The serous is thinner, the mucoidal is thicker, and they produce 60% of your saliva at rest. The sublinguals produce serous and mucoidal saliva as well, and they secrete 15% of your saliva at rest. These three pairs of glands make 3/4 of a teaspoon of saliva every minute. So you have a lot of saliva. When chewing, they produce about a tablespoon per minute. Saliva is composed of 40 essential proteins, 13 electrolytes and minerals, and 7 organic molecules. So our saliva is extremely important in our ability to eat and speak, and so that's why oral care is so important. You need good saliva for lubrication, so it keeps your mouth moist, helps you chew and swallow, it cleanses your mouth. Protection, it limits bacterial, viral, and fungal growth. So your patients who don't have good saliva production often have issues with things growing in the mouth. It protects our mouth from hot and cold temperatures, and it bathes the teeth in protective minerals to prevent cavities. So when you don't have good saliva, you also have more tooth decay. The other important thing is saliva helps with digestion. Our digestion actually starts in the mouth, and saliva breaks down food so you can taste better, and it initiates carbohydrate digestion. So our patients who have very dry mouth often complain that everything tastes bad, and they often complain or they can't taste at all. And then of course for communication, if your mouth is really dry, it's very hard to speak. So I always recommend, if you're going to give meds, to give the patient a little drink of water first to wet their mouth and get that saliva going a little bit, and that will help them swallow better too, instead of giving it with it, in the dry mouth first and then the water. I always give a sip first. The speech bedside includes the assessment of the following areas. So we're looking for how well the patient can close their lips on the spoon, suck on a straw, manipulate the material in the mouth, whether they pocket food or hold it in their mouth. We look at how quickly they initiate the swallow. We watch or feel for the hyoid elevation. We watch for signs of aspiration such as coughing, choking, wet, gurgly vocal quality, upper airway sounds, changes in their vocal quality. I always am leaning over in the bed real close and listening to the patient's lung sounds before and after they drink, because I'm listening to that upper airway. And then we watch for other subtle signs such as watery eyes, runny nose, sometimes running a low-grade temp can be an indication. So there are two things on a swallow study and at the bedside we watch for: penetration, which means that material enters into the larynx but not through the vocal folds. So it goes into the laryngeal vestibule, down to the level of the vocal folds, but it doesn't go through the vocal folds into the lungs. So sometimes people will have some penetration, or they'll have what we call deep penetration, where the liquid or the food goes partially the wrong way, but then when they swallow it kind of pops back out and goes the right way. So those patients maybe didn't actually aspirate during the swallow test, but they're at high risk for aspiration because their food goes the wrong way. And then aspiration is when the material actually falls through the vocal folds and into the lungs. So episodes of both penetration and aspiration can occur before, during, or after the swallow. So lots of times people say, well, they have a swallow. Yeah, they have a swallow, but they're aspirating during the swallow, or they're aspirating the residue after the swallow. So that's important to know. In addition to evaluating for penetration and aspiration of material into the airway, speech, one of the reasons we ask for swallow studies often is because we need to evaluate the anatomical and physiological aspects of the swallow. So we want to see, where is the problem? Are they aspirating before the swallow because of poor oral control of the bolus? Are they aspirating during the swallow because they don't have good airway protection? Or are they aspirating after the swallow because they have residue in there? Or the muscle at the top of the esophagus isn't relaxing enough to let the bolus go through. And so there's a lot of things that we need from a swallow study. I know we have a tendency to talk about a swallow study in terms of pass-fail, but for us it is not a pass-fail. There's a huge variation of a variety of things we're looking for. So this is just what a swallow study is, and I wish I could have attached a swallow study for everyone to see, but I tried, I couldn't get it. I even went on YouTube and was going to upload one from YouTube, but they didn't really have very good ones on YouTube. But you can go on YouTube and look. Or the other thing I wanted to say is, now we just got new swallow equipment, and so all of our swallow studies are going on to PACS. So you can pull up a patient swallow study on your unit on PACS and watch it. So that just started last month. So, you know, sometimes you hear it called a cookie swallow, a modified barium swallow, a video fluoroscopic swallow study. They're all the same thing. And that's where we look with X-ray at how the patient is swallowing. And again, it talks about it's more than just whether the patient is aspirating or not, but it assesses the amount of aspiration, the timing, the anatomy, the physiology, and we can do compensatory strategies and different consistencies so we can figure out if there's anything that we can do to help the patient eliminate aspiration or swallow more safely. The water swallow challenge is a screening that nursing performs. It started really mostly with stroke patients. It's mostly supposed to be for stroke patients, although in ICU the nurses use it a lot for patients who have been intubated, and that's okay too. We don't really recommend it on the floors as much. I mean, on the stroke floor, of course, but some of our pneumonia patients and other types of diagnoses, we prefer that speech do the bedside on those diagnoses. But, you know, if you need to screen the patient before you give them meds when they first come in, you know, by all means. So successful uninterrupted drinking of all 3 ounces of water without any overt signs or symptoms of dysphagia. And by overt, we mean coughing and choking. Although certainly you're going to pay attention to some of the other subtle signs that I talked about just a minute ago as well. If the patient passes, then you collaborate with the physician to decide what type of diet to order. The inability to drink the entire 3 ounces in sequential swallows, or if they're coughing or choking, or if you notice changes in the upper airway, wet vocal quality, shortness of breath right after drinking, then we recommend that a speech evaluation be ordered, and that can be a bedside or a formal swallow study. If you're not sure how a patient's doing, by all means order a bedside. If you're sure that they're having a lot of difficulty, then go ahead and order the formal swallow study. We can go either way. So this is the screen for the water swallow challenge, and I wanted to make sure that we talk a little bit about exclusions. So it's important to realize that patients who are already on speech therapy for dysphagia, you need to refer back to the speech therapist if you want the diet changed, rather than doing a bedside, because the patient is already being seen by a speech therapist. Then the speech therapist needs to be the one who's determining whether their diet can be modified. So again, if a patient's already on thickened liquids or has a history of dysphagia, then we really recommend that speech come back in. We have the ability to look at their previous swallow studies, figure out how long ago it was, look at whether they should have still been on a modified diet and weren't. So there's a lot of reasons why, if a patient has a history of difficulty swallowing, speech should probably do the bedside. A tracheostomy tube present is another area where we strongly recommend that speech do the bedside. Tracheostomy tubes can anchor the larynx, so you don't get a good strong excursion of the hyoid for a good swallow. Tracheostomy tubes cause patients to have decreased sensation, so they can silently aspirate more often. The other thing about our new equipment I wanted to mention too is that we now can take patients down on a vent and are in their bed, because we're a lot have a different tube and it's a lot wider, and we can get those bariatric patients in now in their beds without having to move them into the chair. So if they're over the weight limit of the chairs, we can do them now, and we can do people on ventilators. So we can do a lot more things than we used to be able to do. So those are some important things to know. If you have a stroke patient and they just seem to have a lot of facial weakness, poor oral motor movements, I would recommend you just go straight to speech and let us do the bedside, because we can determine whether they need a bedside or need a formal. So anyway, if you've answered no to all of the at-risk exclusion criteria on the previous page, and you've answered no, then you can continue with the water challenge. And so these are just screenshots of what the water challenge looks like, and then you just mark pass or fail. Again, if you're uncomfortable in any way, just refer directly to speech. So that's the 3-ounce water test. The Fraser water protocol I wanted to mention, because we do have this in place here at Memorial, and we use it sometimes, but sometimes we don't, and so I wanted to kind of clarify a few things about the Fraser water protocol. First of all, a physician order is necessary to put a patient on the water protocol, and almost always speech has to be consulted to make sure the patient is appropriate for the water protocol. So what it is it's the idea that patients' lungs can tolerate aspiration of water. And so they've done a lot of research on this and found that aspiration of small amounts of water doesn't seem to have a negative effect or lead more often to aspiration pneumonia. It's more things like food and different types of liquids that cause the patient to develop pneumonia. So small amounts of water they're finding are fine. So patient must wait about 30 minutes after they consume any food and make sure the mouth is clean. So you always perform oral care to make sure the mouth is clean. If a patient is on the water protocol, you don't give their meds with water, because again, these are patients that we know are aspirating liquids, and if you give them their meds with the water, you're putting them at risk to aspirate that med. So the med's not going to help if it's in their lung. And so you still give the meds the same way you do if they were NPO, whether that is through a tube or per the swallow recommendations from the test, whether it's crushed in applesauce or whatever those recommendations are. So the patient, again, must be evaluated by speech to make sure they're appropriate. If the patient is on an oral diet like nectar thick or honey thick liquids, all of their swallow precautions need to be followed. So if they are taking their liquids by spoon, then even the water probably should be taken by spoon. Again, prior to ingestion of water, the mouth should be thoroughly cleaned. Thickened liquids are given with meals if that's what their diet recommendation is. So during the meals they cannot have water, because if we know they're aspirating the thin liquids, you'd be washing food particles down into their lungs with that water. So during the meals they have the thickened liquids on whatever diet was recommended, and then 30 minutes after you do oral care, and then they can have water. Even patients who are NPO, completely NPO, or on a tube feed, they may be on the water protocol with ice chips and water, but again, we follow the same things. Make sure that you clean their mouth well. Usually speech needs to be involved to make sure that they're a candidate. You don't want to give water to people who are coughing and choking so badly that it's causing distress. So that's another person who would not be appropriate for the water protocol. The other thing I always say is I like to limit what the patient can have. Patients can still drown. So if they have severe aspiration and you hand them a full glass of water and just let them drink, they can, it can be too much. So the more severe the dysphagia, the more I kind of limit the water. So just a few ice chips, a small glass of small sips of water. But I usually have the nurses kind of try to control that a little bit. Again, you're going to monitor for signs of aspiration pneumonia, and patients that have thrush or other mouth infections are not appropriate for the water protocol, because again, you don't want those organisms washing into their lungs.
Quick question on this. So you've said it about 1,000 times. So water. Now, what if the nurse says, oh, well, Sprite is clear, 7-Up or whatever we're stocking at the time, those are all clear, so that's the same thing as water?
No.
Okay.
Because the sugars in the other, because it's not just water.
Correct.
There are other chemicals and other things in the pop that can lead to pneumonia, so it's just water.
And is there a recommendation on like how often in a day you would do the Fraser water protocol? Is it just like 3 times a day, like following meals? I mean, because I would think that every hour is probably, if they are aspirating, too much, right?
And it kind of depends on how severe their aspiration is. And so some patients might have what we call trace aspiration, so they're only aspirating a tiny bit. And if they control their swallow, or, their amounts, they aspirate very little. So that patient may be able to have more water than somebody who is a frank aspirator, who's, aspirating 3 or 4 teaspoons in every swallow. So that's where speech kind of comes in. If I have a patient who's really severe, I'll say, please don't just hand them a glass of ice chips and let them sit there and eat them by the tall glasses and eat them by the spoon. But, I'll say, a couple sips. Some patients bargain with you a lot.
Yes, they do.
Now, the mouth cleansing, how often, so one mouth cleanse after they eat, then they can
have it
until they have something else to eat?
Yes, in most cases, unless they, because you can't really do it with people with thrush or mouth infections, so their mouth should stay fairly clean till the next time they get, unless they sleep, in their mouth breather and they wake up and their mouth is all icky, then I would do oral care again. But if they're awake and alert, and you've cleaned their mouth well and you're letting them have some water, they should be fine. But definitely after every time they eat, it has to be cleaned.
Okay.
So I hope, does that kind of answer your question,
Yep.
Bob? All right. So that is the end of the presentation. So anytime you have any question at all about someone swallowing, please feel free to call Samantha or myself to come up and see your patient and do a bedside, and we can kind of make a decision. Or if you think a patient wants an upgrade or doesn't like the thickened liquids, which happens a lot, we can come and reevaluate and see if they can be upgraded. But most upgrades of diets need to be done by speech if speech has put them on the modified diet in the first place. That's probably the safest thing to do. So that's important. And like I said, the cool thing is, if you want to see your patient's swallow study, we can pull them up on packs now on the units, and you can see what's happening. So I think that will help physicians understand when we have to recommend NPO. We can pull it up on our laptops for our families too. So
Nice.
So that'll be a nice addition to the education we do for the staff and the patient and families, as well as the physicians.
So I think the one other question I had was, we do a swallow study. Let's say we do a formal swallow study. To me, it's kind of like a snapshot in time.
Right.
So if the patient then maybe worsens within the next 12 hours even, we still probably need to be fairly vigilant of aspiration. And, we got to think of what is all going on with this person as to why they maybe had aspiration problems in the first place, and think, could this be getting worse over time?
That is true. And so that's one of the things. Number one, we're trying to get away a little bit from saying they passed or failed.
Right.
And talking more about this patient is at high risk for aspiration. So even if they may not have aspirated, or on the swallow precaution sheets, sometimes I'll write must follow swallow precautions. I mean, I can't stress that enough. Many patients, if you control the amount, like taking their liquids by spoon, you can eliminate aspiration. But I don't know how many times I write that on the thing, thin liquids by spoon only, and I go in the room and there's straws in every drink. And so that's important. But any change of condition in a patient who already has swallowing issues, the best thing to do would to make them NPO until speech can come back in and reevaluate, because you don't want to further compromise that patient if they're already having a change in condition. And I've had several patients that I probably evaluated their swallow, 20 times during their stay, just because they fluctuate so much. So you have to use your judgment. If you don't see a good strong swallow, if it's taking them forever to swallow, if they're holding food in their mouth, or they're not alert enough to eat, don't feed.
Right. And I think a lot of times I know staff have trouble getting around that. I'm not feeding my patient, I'm not able to give my meds. And I guess coming from the ICU, it's not that big of a deal for me to stick what literally is just a piece of plastic down into their stomach by getting an NG, giving meds that way. We can switch a lot of things over to IV, and I think that's some communication between the nursing staff and the physicians, because if you kind of push that envelope or just, they might be okay, that's where I end up seeing them in the ICU, because they've now aspirated a pudding snacks. Right.
Or a med.
Right, that too.
Which is almost worse. So yes, you have to keep a close eye. And so our patients who, I know it's a pain for the staff to feed people.
Yeah.
But if a person, it's between a person being able to eat, if somebody is right there making them take their liquids by spoon or taking small bites, versus a person who, needs a feeding tube, it's very important. So I try to think very carefully about the recommendations I make based on that patient's mental status, because there's a lot of things that people can do. Physicians will say, well, why don't you try the supraglottic swallow? And that's a swallow technique. But if a patient can't remember or can't follow those instructions, then it doesn't really do any good. And so I try to make sure I mark on the sheet whether they have to have what type of supervision they need, because if they're liquids by spoon and they can't remember to do that, we really have to have a responsibility to have someone in there to help them eat. And that's important. Here at Memorial, the dietary staff is supposed to leave the trays outside the room if they have any diagnosis of dysphagia on thickened liquids, so that staff can check that tray before it goes in the room as well. Because, for instance, the coffee, it doesn't come thickened. They send a glass of regular hot water, and they have the coffee packet next to it, and I don't know how many times I've found the patient drinking the hot water without the coffee in it. And so that has to be checked before it goes in the room, so that the patient doesn't aspirate.
I think one big important thing you said was, you know, the reason we're having these supervised feeds is because we want this patient to use that function, because if they don't use it, it could very well get worse or lose it. I mean, it's almost kind of like if you don't use it, you lose it type of thing.
Yes, but the other thing is if they're not following the swallow precautions, they're going to be aspirating, and then we're prolonging
Right.
their stay. And of course, while you're in the room supervising them, you're also teaching, because even people with mild dementia can learn, but they need a lot of repetition and cueing. So if we're teaching the patient to eat more safely, you know, our stroke patients too, our right hemisphere strokes tend to shovel food in their mouths, not swallow in between bites, pocket food. And so those patients really need somebody right there to help them. They can do it themselves, but you have to you're teaching them how to eat safely. So that's really important.
Well, thank you.
You're welcome.